I have no disclaimers, nothing to disclose, and only disclosure is some of the material which is presented here is reported as journal articles. The story starts in 1993. We have finished a round and a fresh batch of medical students joined our rotation. And after the round, we were sitting in cafeteria on a cup of tea, and medical student asked, "What is a pediatric surgeon?" So then professor explained that they operate on children. What is the difference between them and others? So this was the discussion. One of the residents who asked, when do you become a pediatric surgeon? So professor pointed out to me and said, it's been 5 to 7 years general surgery and then 3 years pediatric surgery, and all of them, their eyes were like this, and they said it's a very, very long training. I asked a question because I have been 3 years under supervision. When do I become a pediatric surgeon? She said, "Day you can manage and deal with all the complications of in a patient who present with congenital tracheoesophageal fistula." Tracheoesophageal fistula is considered an epitome of pediatric surgery. I said, "Why not conjoined twins?" So she said, okay, they are very rare. Once in a while, pediatric surgeon will get a lifetime opportunity to involved in a case. I said, I will do it. And I asked, have you ever done it? No, I have just seen movies and pictures. So I said, okay, I will do if such a patient comes. So then I started reading as a student what is the incidence of these conjoined twins. In our books reports that it is 1 in 250,000 births. At the same time, books writes that incidence of twinning is 1 in 50,000, but 50%, more than 50 to 60% patients. So by that time, more than 200 publications, and out of which 1,485 full text publications. That shows the interest of medical community toward this phenomena. Moreover, this topic has been subject of discussion on social media, print media, electronic media, and off and on you see news in print media and others that babies were born and this and that. But the history goes back as long as I would say 1689, when a Swiss pediatric surgeon, I would say, pediatric surgery did not existed at that time, separated the first set of conjoined twins, and these twins were just joined by a skin bridge, and he just applied a clamp. I said, I wish I could have such a case. But there have been very interesting history, they're very celebrated set of conjoined twins, like who lived their life being joined and refused to be separated, married, had children, and full life. Mike and Chen is the famous conjoined twin which are talked about in the literature. These are the set of brothers who were born in I think somewhere in Far East, and then they were taken to United States and joined a circus and toured whole world. and married 2 sisters and had 9 children. Interesting, and similarly other stories. But on the whole, public from the start of the history was very skeptical about this. They treated them as a monsters and something which has been put on to this world by God as a I would say sin of society and parents. So then I start looking at these publications, got a copy with the help of my librarian, and start going through one by one throughout these publications. There were about 800 reported cases, but separation attempt was only made in 250 cases. And survival has been very poor in initial years, but after 1990, because of development in anesthesia, intensive care, and other pediatric related specialty, the survival has increased. So this is a collection of famous series reported by large center in the world from US. This is from US, 18 set of conjoined twins, but 5 could not go to surgery for various reasons. So this is from South Africa. Look at, there are 33 patients over so many years, but half of them could not go to surgery for various reasons, associated congenital anomalies, particularly the heart anomalies, because pediatric cardiac surgery was not developed to that extent at that stage. And many of the congenital heart diseases in children were treated as non-correctable, and these children were let to die. And this is interesting from our part of the world. Dr. Rabi, from a friend from Saudi Arabia, he has an organization in Saudi Arabia, and there is a big trust which funds him, and he has connections all over the third world, and where these children are born, they are transferred to Saudi Arabia and they separate. But still, despite they had 29 cases, but 13 could not go to surgery. And similarly, I think most respectable series is of Dr. Spitz, Professor Spitz from Great Ormond Street. They have a fair number of cases and with good survival, and they set the standard of care of these patients. So this off and on, this was discussion in our journal club, in our core curriculum meetings, but we never had a case, although we heard about that patients were admitted to National Hospital for Children in Karachi, but they died after a few days after phototherapy, means photography sessions by the doctors and press media. So this was the first case which we received in 1996. At that time, hospital where I started working has just started coming up. Most of the facilities were getting available. There were some specialists who were there, but some of the diagnostic facilities were not available on the campus, like CT scan. We had our own CT scan in 1995 and MRI in 2000. So we have to send these children or patients out from the hospital to Karachi X-ray or other private diagnostic facilities for treatment. So this child, this is a partial, I would say partial twinning. Look at this. This is a child, and he presented with intestinal obstruction, and perhaps was second or third case who was admitted to our NICU with intestinal obstruction. He was draining bile from the umbilicus, and look at this structure. Ear, arm, nose, and half of the embryo was made. So on CT scan, what filled this cavity was the liver. And then we operated at that time. To remind, liver resection just was used to be with the finger fracture technique, and we did not have high energy instruments which are available, organ laser, CUSA, and all those. The blood loss in our first case was 50 cc. 50 cc blood loss in a newborn is a lot, and we keep on questioning and what we will do. If we had a child with a liver tumor, how we can reduce this blood loss in a resource constrained environment. But this was the question which we put in our mind, and we keep on exploring. He had there was a portion of intestine which were joined at duodenum. So we resected the liver, reconstructed the duodenum. Abdominal wall reconstruction was not difficult, as we borrow the skin from here. And this child is now, I would say, is a young man who has gone to university, married, and he, before I came here, he brought his son for circumcision to my clinic. So then 3 years later, we had our second patient, and this was again a parasitic twin. 1.5-year-old female with anorectal malformation. Anovestibular fistula was here, and she has a third leg. And when we did a CT scan, we could not see the sphincter in this part, but sphincter was in this part. So challenging problem, So both pelvis were joined, and so were the vessels, and we did this surgery in collaboration with orthopedic, vascular, and many other my colleagues. So as I said, CT scan was used to delineate anatomy. Anorectovestibular fistula, we did a SARP with relocation of anal sphincter from the parasitic twin, and removal of extra pelvis and limbs. Soft tissue coverage, which is a problem in these patients, is not there because we use the skin of other twins, which has to be discarded, I would say. So, and there was no ethical issue in this. So that's this is again now a young girl went to university. You can't recognize when she come in a makeup to a room, to hospital. And she later on became a supporter and joined our welfare group, who helped the children with complex anomalies and raise funds for us to treat those children. And then we have to wait another years that actual conjoined twin comes to our hospital. It was 1998. By that time we had CT scan, all the specialty, everything. Did not have an echocardiography, and there was one pediatric cardiologist in the whole city of Karachi, and with own echo machine, and he was very kind. He was excited when I went to meet him and request him to do an echo on our patients. This was a set of thracophagous. They were joined from the thorax and abdomen. And he has a very complex congenital cardiac anomaly. Pediatric cardiac surgery has not yet established in Pakistan, and our children will cross the border to get treated for congenital anomalies. And some of you might remember patient going to India, Singapore, and other countries for treatment of congenital anomalies. So after investigation, he had a 6-chamber heart. It was not a case for separation. Other organs shared were liver, and we don't know about the GI. So there was an ethical issue, and the ethical committee and we all sat down and decided that we should not operate on this set of conjoined twins. So this set of conjoined twins were given loving, tender care and lived for 6 months and died because of cyanotic heart disease. Then we have to wait for a long time. Then our 4th case comes 2014. By that time, I had become attending professor, medical director. So then our 4th case came, and this was 2 little girls who were joined from the thorax, abdomen. And here you can see the CT scan, 2 pericardium joining here, heart were separate, and they were joined by a large bridge of liver, and some part of the intestine was joined. So they also had a congenital heart disease which is called Pinktoff, and they were separated at the age of 5 months. It was a team approach, and this was the first time we did in AKU, and probably first time in Karachi, and it was the 2nd case in Pakistan, on which attempt was made to separate. So a 50-member, I would say 50 healthcare worker, including doctors, nurses, OR technicians, and I will come to this later, which were the healthcare worker involved in the separation of conjoined twins. After constituting a team, then we start training the team, held a dedicated session and assigned what is the role of each member on the day of operation, and did a dry run. One of my recovery room nurse, she prepared a dummy on which we could practice a few times. Our anesthesia can practice by putting lines, and because they had a change in the position during operation, and that was practiced before we took the patient to the OR. The surgery took about 8 hours. And this also gave opportunity to our anesthesia colleagues, because many studies like CT scan, MRI has to be performed under GA in the radiology, and they devised techniques, and which later were reported in the international literature. So it was educational, I would say, educational exercise for us. What we learned, as I pointed out, in first twin we lost 50 cc of blood. But in this case, we devised a technique, a simple technique, which we reported in the literature in our prime pediatric surgery journal, rubber tunicate technique to reduce the blood loss during surgery. What this technique is, after separation, we left the liver as such, passed two Penrose drain on each side at the proposed site of separation, tunicate it and divide the liver, and slowly release the tunicate and ligated vessels. With this, it was a success, and we only lost 10 cc blood during this operation. And then with this rubber tunicate technique, we also applied to a 3-day-old neonate who was admitted to our NICU with the congenital hepatoblastoma, a common tumor in pediatric age group, but rare at this age. Only 50 cases operated, and we used this technique and were able to resect this large tumor from this baby without any complications. So this is a picture 3-4 years later. These two girls which were separated, both had a different personality. One with the congenital heart disease is very smart, over smart I would say, than the other peer. They have started going to school now, big girls, and always come to hospital and gather a crowd around them. One of them, who had a pink top, had a pediatric surgery a year later. By this time, pediatric cardiac surgery has established in our institution. And they were able to do a one-stage reconstruction of this top, but post-operatively she developed a heart block, which is usual in such surgeries sometime, and had a permanent pacemaker. But when she come to the hospital, you can't make out that this child has a permanent pacemaker in his body. She is so lively, healthy, and wanted to be a doctor. So our fifth case was in 2020. Just I had started preparing to come here at that time. This was 8-month-old set of twins, which were referred through an NGO, which is being headed by one of the first patient I discussed. She brought the patient to the hospital, arranged funding and all those things. So they were apparently very healthy. Heart was healthy and just had a shared liver, had pectus excavatum, and some part of the intestine were joined. And peculiarity in this surgery was that the COVID-19 pandemic was at peak at those days, and we had this dilemma: should we wait or should we do it in the pandemic when the hospital was working at a very reduced level, you know? So one of the twin who was of a smaller weight used to get sick, you know, off and on. So the team decided that after all the precautions, we should go for separation. So by this time, diagnostic facilities in the university hospital were well established. We had a lot of softwares, and it was an easy, I would say, easy journey. And we had software which could reconstruct the anomaly for us and look at the extra vein which was crossing the site of union and directly opening to the heart. and this is a HIDA scan showing 2 separate gallbladders, and if there is a 1 biliary tract, again that's not a case for separation. So that these imaging was available, and we were lucky to evaluate these children. So again, surgery took a long 8 hours. We were able to do it successfully, but post-op course was stormy. In first 48 hours, they had a hemodynamic instability and systemic inflammatory syndrome, which our intensivist thought it could be a COVID. It could be a COVID, but successfully, they hats off to those intensivists and pediatricians who managed these children successfully, and we were able to discharge them on 14 post-operative day from the hospital. Another thing which we learned during this, that the LFT deranged. There was a rise in the direct and indirect bilirubin in 10 days post-op, and then slowly start coming down. And perhaps that was the natural thing when you do an extra liver resection even in a normal humans. So, but story did not end it. 6 months later, one of the Ayan and Oman, and Ayan presented with adhesive intestinal obstruction, and we have to operate on him again. One of them developed febrile seizures, and for which he is on anti-seizure drugs. So I talked about the team. So the constitution of team. Look at the kind of expertise and which were involved in this surgery, starting from pediatric surgeons to residents, and all the residents want to get involved in such a case, so we have to constrain them, and we have to arrange a TV for them to see the operation outside to reduce the infection. Anesthetist, 3 anesthetists, consultant surgeon, consultant anesthetist, aided by 4 residents and 3 technicians. OR techs and coordinators, pediatric cardiology team and pediatric radiology, pediatric intensive care, nurses, audiovisual and marketing, public affairs, and security. Security is a big issue because everyone in the hospital and the media want to come and see these children. We made a rule that no one should come to visit these patients except the only team which were assigned to look after these. And this way we were able to protect these children not only from mental protection but also infection control as well. PBSD and these patients, these are very costly operations, and they involve a lot of resources, and no parents can afford them. So they, as I said, the funds were generated by one of the patients and other NGOs, and some were chipped from the welfare. In fact, the whole hospital is involved. Hospital, OR administration, clinical affairs, HEC, that's Hospital Ethics Committee, and other specialties if needed. This is what I talked about, one of our nurse prepared dummies for practice, and we constituted the team and then start having sessions with them, and in those sessions we shared the information through serial meetings, emails, and informally define a role of each member, seek candid input from members to plan the procedure, prepare the OR and organize med-surg supply, and did a dry run, full dry run a day before surgery. Ethics and consent is another chapter I don't want to dwell on. In the university, many ethicists, and they had a lot of questions to the team when we were going for this operation. Surgery, in fact, I would say in this case was not difficult. It was a joy. I did not did anything just except for holding retractor for my colleagues and residents who did the operation. So, but remember, in such a surgery, surprises are common. You should be prepared for a surprise. You don't, despite extensive workup, you cannot delineate every anomaly. So that's all. This was a glimpse, and most important part, as I pointed out, these are major surgeries. These patients can require monitoring and the continuity of care and follow up by the same team, same pediatrician, same intensivists makes a difference. So in conclusion, the separation of conjoined twin has been a unique clinical, surgical and educational experience, at least for me. And it also helped us, it was an opportunity for us to promote a team and quality culture in the hospital. I was wearing hat of CMO or medical director, associate dean at that time. So we use this case to inculcate that culture in the hospital. So as I explained, the dry run before surgery and planning about the surgery is a key to success. The rubber tourniquet technique, which is now well established, and our paper has the highest number of citation and is been used by many surgeons around the world, and I usually get an email and a telephone call and they want me to explain it. So this is very simple technique, no resources, but just I think reflect the innovation culture in the institution. So we can do the same in this hospital at this stage, when not all the specialties are developed, not all the diagnostic services which should be in this hospital are not developed to this stage. But this stage it should be performed. Long-term follow-up, I just explained, it's so important for these children. So this is one of the recent picture of these Aman and Ayan, and on this Eid, when I was in Karachi, we celebrated their second birthday in the hospital. You know, they're big boys. This is a picture, whole team gathered on the day of discharge and said goodbye. And when I reached home, this is a picture in my garden. I saw two separate flowers in my garden, perhaps depicting successful separation of conjoined twins. Thank you. The training of a trained driver. They are not trained to put a foot on the accelerator and run it fast, because they will do it and it will run fast because track is there. They are trained to stop the train. You must have heard on the platform कि फलां ट्रेन फलां बोगी फलां जगह पे खड़ी होगी और उसी जगह पे खड़ी होती है. So that's the training, which you go through as a pediatric surgeon. You have to restrain yourself. And that's the first thing which I have learned. I just demonstrated recently in that clinic the boy with the tongue laceration. So If it was a usual thing, no thought process in it, oh, चलो OR ले चलो, पुटोस टांके लगाओ 2-3 और स्टिच लगाओ. So इसी तरह these cases, I think you can only be successful if you work as a team and you put yourself behind the team rather than on front of the team, and support the team, educate the team, and support them. And both of the operations, most of the operations were performed. I just supported my colleagues and residents to do these operations. Very little, I would say. At the stage of separation of liver, I actually did something. The rest of the things that keep people motivated. So excitement, yes. Unless you control your excitement, you can't get the result. But you can't separate them. How can you chop off one head and sacrifice that and have the other? That's an ethical issue.
The interesting question was, because the two separate brains and they work separately. So
yes.
one could feel full stomach, another could feel hungry. So something like that is very interesting.
Yeah. So this is very interesting. I would say, I haven't touched the social aspect of this. How these that's a subject of research. We are following these children in the university and monitoring their social development as well as professional development. And this is an area which required still a lot of research.